substance abuse. She's a member of the VA Women's Health Task Force and has been a speaker at several national VA Women's Health conferences. She received her medical degree from Pavlov Medical University in Russia and completed a residency in psychiatry and a fellowship in addiction psychiatry at UMDNJ Robert Wood Johnson Medical School. Her talk is entitled Substance Abuse in Women. Please welcome Dr. Elena Volz.
Good afternoon, everybody. I understand it's Friday afternoon, it's the end of the week, and it's kind of hard to keep hearing lectures one after the other. So I'll try as much as possible to be quick and practical. I understand most of you are interested in the practical approach, so I won't bother you with many theoretical issues, just so that you can understand the addiction process better and treat your patients better. Thank you very much for the kind introduction. Thank you very much for inviting me. And I have no financial interest to disclose. I wrote a chapter on updates on addiction neurobiology recently at the APA textbook on geriatric neuropsychiatry with my boss David Oslin. And over the course of writing the chapter, I realized many important things, new understanding of addiction that we have now that I haven't learned as when I was an addiction psychiatry fellow, and I wanted to update you on some of the current findings that are important. Also, we'll look at the epidemiology and neurobiology of substance abuse and how hormones influence substance abuse and the gender differences in acquisition, escalation, dependence, withdrawal, relapse, and treatment of substance use, and the differences in psychopharmacology. Whether one is male or female is one of the most important determinants of human health. I found that quote in the WHO, in the World Health Organization's many documents, and that was quoted in many research papers after 2002. And gender is definitely a vulnerability factor for substance abuse, with women being more vulnerable than men. Addiction is a very multifactorial and heterogeneous disease with dysfunctions occurring at different levels. And we need to tailor our treatment to the level of dysfunction. If the subcortical drives and urges and cravings are very powerful, we need to suppress them with medications to free up the cortical space to do the recovery work for psychotherapy and to reestablish the cortical control over the subcortical drives. So addiction is a compulsive and relapsing disorder with two essential features, as we understand it now: impaired ability to regulate the drive to obtain and use substances, and reduced drive to obtain natural rewards. And it's a significant change in the reward circuitry. Nothing that used to be as important as essential for survival, nothing is important anymore as compared to finding and using substances. So substances usurp normal learning circuitry to create the pathology of addiction. There are different vulnerabilities in development of addiction: genetic, developmental, social, and also what happens in the brain with the brain plasticity as a result of chronic administration of different substances of abuse. There is a core addiction syndrome. It turns out that it doesn't matter which substance the person is addicted to, the changes in the brain will be similar. Ultimately, with the chronic administration of the substances. Addiction is overlearned. We used to understand that addiction is all about dopamine, but dopamine is important in any learning process. And when you're learning to become addicted, it's very important. But then the maintenance of addiction process and is maintained by glutamate and GABA, the stop and go. And we need to address that glutamate and GABA dysfunction when we treat our addicted patients. There is a significant reduction in the executive function, hypofrontality, across every substances of abuse, what happens. And the drug-associated stimuli activate frontal lobes much more powerfully as compared to the any other natural reinforcers, sex, food, danger, anything that is important for survival. It's a very maladaptive process. There are certain stages as how addiction develops: abstinence, social use, chronic use, and there is a stage of regulated relapse when there is still an ability to make a conscious decision over the use. And the most advanced stage of an addiction is when a relapse becomes compulsive. There is no more cortical work, no more executive decision over the use, and no more conscious choice. And the goal of treatment would be to reverse the changes. It's impossible to unlearn addiction. Whatever was established in a circuitry will remain there forever. You need to, the goal of treatment is to establish new connections and learn how to live with a different focus. So to sum this up, there are certain dysfunctions that occur with every chronic addiction. There is a disruption in motivation and reward circuitry involving dopamine and endorphins, glutamate and GABA, HPA axis dysregulation, hyperfrontality, sex hormones dysregulation, and significant cravings and relapse. It's not surprising that we do not have many medications to treat addiction, because it's such a complex, brain is such a complex system. Look at the number of receptors that we have, and they all modulate dopamine release, and they all modulate the addictive process. We know at least 5 types of dopamine receptors, 4 types of glutamate receptors, and they're all listed here. Serotonergic receptors, at least 14 types are known at this point. And there are many other systems that play into the addictive process. Now, gender research and the differences in addiction. How do you compare males and females? What stage of their menstrual cycle are you going to compare them to? You know, follicular luteal phase, each phase is divided into early, mid, and late phase. How do you make a comparison? Once you try to make a comparison of male and females in terms of their hormones, then we need to also match them up in the level of stress and the level of use, because you can't possibly compare a social drinker, a female social drinker, to a male alcoholic. It just wouldn't work. And then try to select a control group, and then try to have a big enough number of subjects to fill up all the statistical cells that you need for analysis. It's very difficult to do. So, males and females are structurally, they're different, and the brains are different. It's been established, we're not going to debate about it. There is certain structural differences and certain functional differences. Why are they different? Because chromosomal sex determines gonadal sex, gonadal hormones influence brain development, and the hormones that are released by peripheral organs are different between males and females, and there's a different interaction of hormones on the brain. Traditionally, substance abuse was considered to be a male disease, and currently we know that men are twice as likely to meet the current DSM-4 criteria for any substance use or dependence, twice as likely as women. And this is a data from SAMHSA, from a National Survey of Drug Use and Health from 2010, the most recent data that shows us that this holds true for for most of the age groups, except for this 12 to 17. This is a developing trend that we've observed statistically from at least 2002 for about 10 years. And it's a very alarming trend that young females are catching up and with males in terms of their substance use. The alcohol use by gender is here on this slide. Generally, the gender gap in alcohol is the widest. The smallest gap is in nicotine, in tobacco dependence, and everything else is in between. Marijuana use is in between, and the prescription benzos and opiates are also, the gap is a little smaller, but the widest one is for alcohol. Also data from SAMHSA and from National Survey of Drug Use and Health from 2008. The numbers haven't changed much from in 2010. So about a quarter of women use cigarettes. You can read the numbers for your reference. Tobacco use by pregnancy status of women in reproductive age. About 27% of women of reproductive age use tobacco, and about 16% of pregnant women use tobacco. And this is alarming because tobacco is currently implicated in the development of ADHD in offsprings, because nicotine is such a powerful stimulant, and it's causal in the might be causal in the development of ADHD. Also, what we know about substance use in pregnant women, about 20% of them use alcohol. We talked about cigarettes. Stimulants are primary drugs for which pregnant women seek treatment, which is neurobiologically understandable. They feel tired. Pregnancy makes them high level of progesterone, high level of cortisol, and 65% of women relapse within 6 months of delivery. In lesbian and bisexual women, they report higher and riskier alcohol use. Their lifestyle is a bit different, and that plays into the levels of substance use. But the good news is that they tend to seek treatment. They're twice as likely to receive treatment as compared to heterosexual women. Now, this is the pie chart of the initiation of drug use as of 2010. And to understand the real picture, we really have to include alcohol and tobacco in this pie chart. This is also illicit only illicit drugs here. But marijuana tends to play a greater role in the initiation of drug use in men, and tobacco plays a greater role in initiation of drug use in women. So multiple studies demonstrate higher rates of substance abuse and dependence in males as compared to females. Does it mean that males are more vulnerable to substance abuse, or females are less vulnerable? And what I will try to demonstrate you with this presentation is that if given the opportunity, females are at least as likely as males to use drugs and alcohol and to become dependent. And lower prevalence that we see can be explained by less exposure and fewer opportunities. Throughout the history, and I'm not an anthropologist, but throughout the history, in many nations and many cultures, there were taboos, specific taboos on women using drugs and alcohol. And those taboos are probably were there in place for a reason, because they were protective. And now, because the secularization of society and the women's strive for equality, this is changing. Probably people have noticed over centuries that if a woman starts using drugs and alcohol, she deteriorates much faster than a male. So there was a study done in 1999, where they've calculated the opportunity to use drugs in males and females. And it turned out that the males had many more opportunities. They were exposed more. But then they've recalculated the same data with a conditional prevalence. What was the use in those who were exposed? And the gap closed up very quickly, and in some of the substances, as you can see, women actually outperformed men. And based on another study, the researchers were able to calculate that males and females are equally likely to become dependent on cocaine, tobacco, heroin, inhalants, hallucinogens, and opioid analgesics. But men were more likely to develop dependence on marijuana and alcohol, and females were more likely to become dependent on anxiolytics, sedatives, and hypnotics. There is a phenomenon, telescoping, where females escalate their substance use and rate of consumption and develop a greater dependence within a shorter period of time. And this phenomenon was demonstrated for many different substances, for tobacco, caffeine, alcohol, cannabis, opiates, sedatives, cocaine, inhalants, amphetamine, pretty much for every single substance out there. In a study done at Penn, it was demonstrated that within 24 months of cocaine use, females were 3-4 times more likely than males to become dependent. We also know that girls develop tobacco dependent symptoms faster than boys. Animal models confirm that greater female vulnerability. In animal studies, females compared to males self-administer more alcohol, caffeine, cocaine, fentanyl, heroin, morphine, nicotine, cannabinoids, and other substances. They acquire stronger cocaine-induced conditional place preference, faster at lower doses, and acquire self-administration faster than males. And in some animals, 100% of females will acquire self-administration as compared to about 30 to 40% of males. So is the difference due to circulating estrogen and progesterones? Then how to test this hypothesis? You cut off their ovaries and testicles and see what happens. And they did. And it turns out that even ovary-actomized females and castrated males, when they compared with castrated males, they still self-administered more substances. So the conclusion was made that this is not due to circulating hormones, but due to the brain organization in response to during early development. It would be for an obstetrician and primary care physicians here, it would be a nice study to do, to see what's going on with substance abuse in women who have undergone the ovariectomy. It would be very nice to look at this. So, estrogens and progesterones are neuroactive hormones that influence not just peripheral organs, but they have a modulating effect on all the neurotransmitter systems in the brain. And during the menstrual cycle, there are peaks and valleys where women would be more or less susceptible to the effects of substances. Estrogens. How does estradiol affect the brain? Estrogen enhances cholinergic and glutamatergic systems, leading to brain activation in both male and female brains. It affects memory, learning, cognitive function. Male brains synthesize estrogen from the testosterone, both glial cells and neurons. And MRI shows the increase in blood flow to the brain in response to estrogens. Now, estrogens also lead to more dopamine release, which is implicated in addiction. And they directly influence the dopamine receptor activity. There are other mechanisms involved, and they inhibit GABAergic interneurons. So when they inhibit the inhibitor, and more dopamine is released. They also activate HPA axis. Progesterone has an opposite effect on the brain. Progesterone and its metabolite, allopregnanolone, produces a sedating and calming effect via GABA-A receptors. And hence, allopregnanolone is a powerful anxiolytic, anticonvulsant, and anesthetic. And when you're in a withdrawal of allopregnanolone, you develop more anxiety, seizures, migraines, and pain. Serotonin facilitates the metabolism of progesterone into allopregnanolone, and some of the serotonergic medications might be helpful in treatment of women premenstrual dysphoric disorder. And progesterone also leads to the HPA axis deactivation. So, in at least 2 studies, it was showed that enhanced drug seeking and subjective effects of substances were related to the higher levels of endogenous estrogens. And estrogens cause that a higher release of dopamine, which is implicated in development of addiction. And the telescoping phenomenon that we observe in females might be explained by this vulnerability. That was shown, the same thing was shown in animal models, that if you give animals estrogen, they will develop self-administration faster. Dr. Jill Becker in the University of Michigan, she does very nice research on this, animal research, and she studied the intensity of behavioral response. There is also a difference in the concentration of D1 and D2 dopaminergic receptors in male and female brains, and that plays into vulnerability of addiction because D1 activation decreases the high from addictive substances, and women have less of D1 receptors as compared to males. And the delta of dopamine from the baseline level of dopamine and the achieved level of dopamine in response to stimuli is much greater in females, and that's implicated in addiction because the more dopamine is released, the greater the cravings are. And cravings are implicated in relapse and the maintenance of addiction. So progesterone, on the other hand, attenuates the dopamine release and responses to drug abuse. It inhibits cocaine self-administration. It was found in the studies. And women that were treated with progesterone showed a decrease in the positive subjective effects of cocaine. They hospitalized women who were cocaine dependent, gave them 150 milligrams of progesterone twice a day, and it was shown that it attenuated the high from cocaine and their drug-seeking behavior. And the high circulating plasma level of progesterone were associated with decreased cravings following drug and stress-related cues. Now, so, peaks and valleys in the menstrual cycle, 2 weeks up, 2 weeks down, and that influences the enjoyment of substances of abuse. When the estrogens level are higher, women enjoy substances during the first 2 weeks of the cycle, and then they cannot enjoy them as much in the second 2 weeks of the cycle. And we need to look into it and always know where, if you have a patient and she's of reproductive age, she comes to you, you need to know where she is in her menstrual cycle. It will open your eyes on many symptoms that she reports. Now, the other important aspect is that we respond differently to stress. Cortisol, high level of cortisol has a priming effect on the reward circuitry of the brain. And it synthesizes the brain to the rewarding qualities of substances of abuse. And there are certain gender differences in neurobiological response to stress, and this level of cortisol varies across the menstrual cycle. There are significant mood changes across the menstrual cycle. And the women tend to feel better in the first 2 weeks, as I said. And I always recommend my female patients to schedule, if they have any flexibility in their schedule, and when they need an extra brain boost for their, whatever, auditions, performances, to schedule it right before the ovulation. Because that would be great, that would be the best. And then the mood goes significantly down at the end of the cycle, right before the period. I saw a study where they looked at the 65% of psychiatric admissions in women. They fall into the last week before the period. That, because everything exacerbates. The other practical implication of this is that if you have a female boss of a reproductive age, you might pay closer attention to her cycling and know when to approach her with promotions, with any other things that you need to approach her, just because this is all cyclical, 2 weeks up, 2 weeks down. So there is a significant brain function variability in women that is controlled by ovarian hormones. And in all our studies, we have to control for the phase of menstrual cycle, because 30% improvement is a big deal in the behavioral research and in any other research. And if, we would never know if our interventions had any effect if that 30% improvement was only attributed to the fact that the woman just simply flipped to a different hormonal phase, and we didn't even have, we didn't influence it at all. So we have to control in the research for the menstrual cycle phase. Now, premenstrual dysphoric disorder. Why is it important to talk about it? Because women self-medicate. and women who have premenstrual dysphoric disorders, they tend to use substances more. It's been calculated that all the hormonal levels are normal, but the women react differently to different hormonal levels, to normal hormonal levels, because they have dysfunctions in their GABAergic systems, serotonergic systems, and other systems in the brain. And there is a seasonal variation to symptom severity due to lower serotonin levels in fall and winter. So your PMSing, substance-abusing women will be using more substances in the fall and winter, right? So, there is a list of catamenial disorders, fancy name for disorders with premenstrual exacerbation. Includes mood, anxiety, psychosis, migraine, substance use, seizures, allergy, asthma, sleep, and pain. And if you conceptualize premenstrual dysphoric disorder as a state of GABA-A and endorphin withdrawal, then it's very understandable why women would crave and use more alcohol and benzos and opiates right before the period. Women with premenstrual dysphoric disorder drink more heavily than controls and have higher rates of alcohol abuse and dependence, demonstrated in multiple studies. And Valium was considered to be a little mother's helper for many years, and it definitely has a neurobiological basis for it. And that all this mommy needs a glass of wine, we all, this has a definitely, when mommy is PMSing, she might use something GABA-A that quiets down her GABA-A withdrawal, whether it's barbiturates, benzos, opiates, or any other sedative. Now, there is a significant gender differences in brain imaging in substances of abuse. There are many more areas in the brain that are activated in response to stimuli in the brain, and not just substance abuse stimuli. So I think women's brain are more sensitive generally to different kind of stimuli. And there's substance abuse-induced brain shrinkage might be greater in females, and some other substance-induced perfusion deficits and the neuronal damage are greater in males. Look at this study that was done at Penn, University of Pennsylvania. They're all smokers, and they're given smoking-related cues. Look at the intensity of brain activation in females and males. Like there's 3, 4 maybe little dots that are hard to see in males, and look at the areas of activation in the female brains. So, there is a significant difference. And with the advances of neuroimaging, we can understand more why women use more, and differences in motivation. I will leave this slide for you to read. There are many. It's a developing area of research. There are more studies coming up with different substances, and there are significant differences in the relapse. Women relapse for different reasons than men. Relationships are central in women's life, and sometimes they're ready to compromise their own health for the sake of relationships. Untreated psychiatric disorders, especially depression and trauma-related symptoms, play a greater role in women as compared to men. There are significant gender differences in medical consequences of substance abuse. For example, for female alcoholics, their death rate is 50 to 100% higher than for male alcoholics. And they develop more severe consequences of substance abuse. There are differences in co-occurring disorders. Generally, the pattern seems to be what we see in general population. Women have more mood disorders, anxiety disorders, eating disorders, and men tend to have more antisocial personality disorders and pathological gamblings and all of those things. So regardless of substance use, they have similar patterns of comorbidities. In terms of mood disorders, there is a 2-to-1 ratio of male to females. Whenever there is a hormonal change, women are twice as likely to get depressed. We used to think that this ratio goes down. It's 1-to-1 in childhood, then it goes, it doubles with the onset of puberty, and it stays that way throughout life. It doesn't go down after the menopause. Women tend to have a primary mental health disorder that antedates the onset of substance abuse disorder more often than men. And in one of the studies, women with depression were more than 7 times as likely as women without depression to have alcohol dependence at 2-year follow-up. I think we're going to, skip some of the slides, and I wanted to go to the treatment aspects, so practical aspects. Women metabolize many substances faster than men because there's a significant, difference in the activity of P450 enzymes. They metabolize nicotine faster, and it's related to their hormonal levels. Because it's equal in men and postmenopausal women, it's faster in women on oral contraceptives, and faster in pregnant women than non-pregnant women. Tobacco plays a greater role in the development of other drug use in women, the transition to other drug use. How do we treat tobacco dependence? We have to give women enough of nicotine. Nicotine is not harmful to the health. Nicotine doesn't harm brains, blood vessels, heart, lungs. It's the other stuff in tobacco, about 4,300 compounds with 63 known carcinogens that are in tobacco. Nicotine doesn't harm, and that's one of the misconceptions. How do we calculate how much nicotine a woman needs? It's been calculated a long time ago. Pharmaceutical companies developed 2 milligrams and 4 milligram gums and lozenges, and that's the range what you get per cigarette, but women tend to metabolize it faster, so women would use 3 to 4 milligrams of nicotine per cigarette. So in other words, if a woman smokes a pack a day, she would need 60 to 80 milligrams of nicotine a day to control her cravings, and putting a 21 milligram patch on her would not, would not be enough. So you have to supplement the patch, either do double patching, triple patching that has been done, and they can continue smoking on the patch, actually. That's one of the other misconceptions that prevents so many women from quitting smoking, because providers tell them, if you have a patch, you can't smoke. This is not true. So the combination of nicotine replacement is the most effective, as according to the Surgeon General report from 2008. It's the most effective way to treat tobacco dependence. So we need to give enough of the nicotine, and we simply do not give enough. Varenicline and bupropion are also very useful in treating nicotine dependence, but the odds ratio of quitting is higher with combination nicotine replacement. Now let's move to alcohol quickly. Women tend to have a lower content of body water, 51% versus 65% in men, and that content goes down with age. There are low levels of gastric alcohol dehydrogenase, 25% of men's, and there is certain menstrual cycle-related variability in the blood alcohol concentration. If women ask you what's the healthy level of drinking, it is for females under 65, no more than 3 standard drinks per day, and no more than 7 per week. It's considered to be a low-risk drinking if there is no heart disease involved. Women start drinking later and consume more alcohol. Some of the women, due to societal stigma, hide their alcohol use very well, and they get medicated with sedatives and tranquilizers, which only make things worse. So how do we treat alcohol dependence? Disulfiram antabuse is no longer, nobody uses it anymore. I was trained in addiction psychiatry, I've never used it. Naltrexone, oral naltrexone is very, very useful, or injectable naltrexone, not just for alcohol, for opiate dependence and for many other addictions. It seems to be very, very helpful because it affects that general endorphin release mechanism. Acamprosate is useful in treating alcohol dependence, although in Europe it seems to be more effective than here in the United States. Topamax is another medication, and for some subset of alcoholics, Zofran, ondansetron, has been found to be very helpful for their alcohol dependence. There are certain differences in how men and women respond to treatment that we provide for substance abuse. Disulfiram is actually used now for cocaine dependence treatment because it affects the enzyme that affects the metabolism of dopamine. So, but it was useful for cocaine dependence in males, but not in females. Nicotine replacement was more effective in males than females because I suspect that we simply, again, for the reason I described above, we simply do not give enough. And the local study done in Penn, when they tried to treat alcohol dependence with sertraline, it was effective only in males, but not in females. And for whatever reason, response to oral naltrexone is similar to males and females. However, injectable Vivitrol is less effective in women. There are other medications that we use for treatment of addiction, and I would be happy to answer the questions in details after the lecture and in the hallway. Buprenorphine and methadone, women metabolize them faster, so they tend to require higher doses. There is no difference in response to acamprosate. It's teratogenic in human studies, so you have to be careful with women in reproductive age. Anticonvulsants are very effective for treatment of any addiction disorder, but the anticonvulsants that are safe to use even in pregnant women are gabapentin and lamotrigine. The rest of them are teratogenic and have many undesirable side effects. Baclofen GABA-A agonist is used sometimes for treatment of alcohol and cocaine dependence. Varenicline, there is no difference in responses. It's been actually specifically studied. Ondansetron, I mentioned that it's useful for a subset of alcoholic, Cloniger type B, the ones that start drinking very early in life and have antisocial personality disorders. Progesterone. Progesterone was given, and I've told you the studies were 150 milligrams BID, tend to attenuate the pleasurable effects of drugs. And I haven't seen a study where progesterone was actually given to males, but in women it seems to help for cocaine dependence. All right, I think we're out of time. 3 more minutes? Okay, so we can discuss, if you want me to talk about treatment more in details. Let me go back. How do I go back to this previous slide? Buprenorphine, the partial agonist of mu receptor, extremely well tolerated in medically compromised patients, in elderly, doesn't cause as much of the immunosuppression as other opiates. Methadone is a gold standard of opiate dependence treatment. The additional bonus of methadone includes that it's actually a racemic mixture of 2 isomers, in which one is an opiate and another one is NMDA antagonist, which is a built-in bonus, because in a chronic treatment of methadone, patients do not develop paradoxical hyperalgesia and all of those neuroplastic changes that they develop with any other chronic administration of opiates. So methadone is a very good, traditionally 40 years of use. Acamprosate, has a very weird dosing, 333 milligrams 3 times a day for a week, and then you go to 666 milligrams 3 times a day. I had an alcoholic priest once that I've treated, and he said, under no circumstances I'm taking 666 3 times a day. So that didn't work. But in many, I've treated addicted professionals at Princeton Medical Center. We had a special unit where we treated addicted professionals from, all of the, Manhattan and, New Jersey, and everybody else tolerated it well except for that person. Baclofen, very poorly tolerated because it can be very sedating. Varenicline, very easy to use. In the future, we'll see that it's not just useful for tobacco dependence, it might be useful for any other addictions. And ondansetron, again, I saw studies from 8 milligrams to 32 milligrams a day. It's a 3-HT blocker. Progesterone, I already commented on the dose. I think we should wrap up. Okay, let's move to question and answers.
I have a question about low-dose naltrexone I'm over here. Hi. Low-dose naltrexone, do you see any role at all for that, like the 4 milligram? I've just seen a couple of small articles about that.
I've seen articles about it. I don't treat the autoimmune diseases like lupus, and so I can't comment